today's topic is getting into the Ayushman Bharat digital health ecosystem. This topic actually originally we thought we'll do about just digital medicine, but then we decided to do a more focused talk this time. The speaker is Professor Ahmadulla Shariff. He's a professor and head of Department of Anatomy and professor in charge of computer facility, telemedicine facility, and the founder professor in charge of clinical eco-toxicology facility at All India Institute of Medical Sciences, New Delhi. He is my batchmate and he did his MBBS and MS Anatomy from Dicom Tags. Recently, Patta Radhakrishna visited him and sent us pictures. So Shariff, he has established a state-of-art digital and e-learning lab for the anatomy department. He has a rich research experience in clinical eco-toxicology, heavy metal toxicity, enteric nervous system, and developmental biology. He has scores of publications in national and international journals with more than 35 publications in just the last 5 years. Shariff was at the heart of implementing telemedicine facilities during COVID, which helped in dissemination of information to physicians and general public during the pandemic. Thank you, Shariff, for immediately accepting our invitation to talk on marvelous medicine. Moderating the session will be Dr. Sumant C. Raman. He is the co-founder of the health portal www.webhealthcenter.com. He is presently involved in a startup in the area of AI-based clinical decision support system. Dr. Sumant did his MBBS and DCH from Madras Medical College and MD Medicine from Sri Ramchandra Institute. He has been involved with some of the largest IT implementations in healthcare.
For reading like audio belongings, very fast.
Sorry for that. He has been involved with some of the largest IT implementations in healthcare IT space in the area of HIS, EMR, eHealth, telemedicine, CDSS, and health portals in both the public and the private sector. Sumant has been an invited speaker at various national and international conferences. And as you all know, he's a celebrity of sorts, being a sports commentator and a television anchor for more than 24 years. Welcome, Sumant, and thank you so much for readily accepting our invitation despite your busy schedule. Joining the party will be...
Thank you, my pleasure.
Joining the party will be my immediate junior, Professor Nalin Mehta. He's the director of NEIGRIHMS Shillong and has several other responsibilities. Prior to joining Shillong, he was the professor of physiology at All India Institute of Medical Sciences, New Delhi. He did his MBBS and MD physiology from Dicom Tags and his master's in bioethics from the University of Toronto. He was the first Indian civilian doctor to winter over for 16 months for human physiology research at Indian Antarctica Station. He's an academician, researcher, and an expert in medical education. He has over 100 publications in reputed journals and has delivered over 300 invited lectures at national and international meetings. He is a reviewer of National Medical Journal of India, Indian Journal of Physiology and Pharmacology, and Annals of Indian Academy of Neurology. Welcome all of you, and we are very proud and happy to have you all today. Over to you, Shariff.
Thank you, Vidya. Thank you for the nice words of introduction, and I'm very grateful to Radhakrishna for having roped me into this. And it was a pleasant coincidence that he happened to visit my place just a month back, and he has seen the digital infrastructure that we have created. And then he asked me to speak about my experience and my journey through this. And I have been very passionate about IT from our MBBS days, and I always acknowledge Dr. Sethu Raman, our professor of medicine and cardiology, who taught us during our MBBS. And he has started off a doctor's computer club when not even PCs were available. So I think that was the beginning. It was in the early 80s. And from there, we started, and I have reached a place now where I have been the professor in charge of the IT infrastructure at AIIMS New Delhi, and I have just completed my tenure. I just want to put it on record. in March after 4 years of being the professor in charge of the computer facilities. Yeah, thank you so much. Because I have been spending a lot of time following these national digital health infrastructure development, because I just had to steer the All India Institute of Medical Sciences into that ecosystem. And so I thought that I should share my experiences and my feelings about the whole thing. At the outset, I should put it on record that we should be very proud that we have one of the best national digital health blueprints in the world, probably, and we are probably ahead of almost all other countries. So, so that is what I have become so passionate about, this particular national digital health blueprint and the national digital health mission, and which has been rechristened as the Ayushman Bharat digital mission, which has been launched by our Prime Minister. So I'll just share that information. So let me share my screen and I'll start off with that. So sometimes, because of my passion about information technology, I may become a bit too technical. At that time, I think you should stop me. Maybe you can give me some hints by yawning or something like that. Yeah, so I'll try to be as non-technical as possible, because most of our audience are all my colleagues who are healthcare professionals. And there may be other, my friends and some of my relatives, my brother-in-law, and probably my sister is also watching. So probably they are concerned about the digital health infrastructure as patients, or I mean, I don't think of any other kind of stakeholdership they may have. So let me just share my screen and let us start off with this.
In the interim, I'll also thank Vidya and Radhakrishnan for having me over. And Sharif, don't worry. If you go overboard, we'll rope you in.
Thank you. I hope the slides are visible.
Yes.
Yeah. So I just want to put it on record that all the materials and the pictures and the textual material is all from these websites of the World Health Organization, UNDP, International Telecommunication Union, and the Ministry of Health and Family Welfare, and all their affiliate and subsidiary websites. So none of this is in my original material. I should, because I have been following IT for quite some time, I have noticed that the healthcare information systems in a large scale started taking roots only in the second half of the first decade of this century, that is around 2005. So the World Health Assembly in a resolution has urged the member states to consider drawing up a long-term strategic plan for developing and implementing e-health services, and to develop the infrastructure for information and communication technologies for health, and to promote equitable, affordable, and universal access to the benefits of healthcare. And that was in 2005. And in 2013, again, there was a resolution, and that resolution is about e-health standardization and interoperability. I think this is a very important keyword, because until then, the healthcare information systems were in silos, and they were in small scale, being implemented in individual institutions, and no two applications were talking to each other. And the World Health Assembly also urged the member states to consider developing policies and legislative mechanisms linked to an overall national e-health strategy. I think these legislative mechanisms and legal regulations and policies are very important if these e-health initiatives have to be implemented. And that's one of the major concerns of most of the stakeholders right now. Now, these sustainable development goals, there are 17 of them. And these goals are supposed to be realized by 2030, and these were adopted, formulated in 2015. And there was a universal call to action to end poverty, protect the planet, and ensure that by 2030, all people enjoy peace and prosperity. I think we are not very far from 2030. I hope the work on the realization of these goals speeds up, and we are able to achieve most of these goals. So right now we are concerned with the goal number 3, that is good health and well-being. So this goal states that we should achieve universal health coverage by 2030. And this universal health coverage will be integral to achieve the sustainable development goal number 3. And multi-sectoral, rights-based and gender-sensitive approaches are essential to address inequalities and to build good health for all. I think this was the 3rd sustainable development goal. And now I should tell you that we have been very fast, and these sustainable goals were formulated in 2015, and in 2017 we have already considered the when our country formulated the national health policy in 2017, and a lot of emphasis was given to the digital health technologies. I think this forms the bedrock based on which the current national digital health ecosystem has developed. So we will keep referring to this once again. And now see this, 1 year later, the World Health Assembly requested the Director General to develop, in close consultation with member states and with inputs from relevant stakeholders, a global strategy on digital health, identifying priority areas, including where the WHO should focus its efforts. I think so. Now we can say that the WHO was almost a year late compared to us. So I'm very proud of that. I think this is one of the best things that has happened to our country, and the digital revolution is well on its way in the healthcare field in our country. So I think everybody has realized that information and communication technologies are the main enabling factor. So there was a growing consensus in the global health community that this strategic and innovative use of digital and cutting-edge information and communication technologies will be an essential enabling factor towards ensuring that 1 billion more people benefit from the universal health coverage, that 1 billion more people are better protected from health emergencies, and that 1 billion more people enjoy better health and well-being. So this is one of those WHO's triple billion targets, which was included in the 13th General Program of Work. So there are some specific objectives have been formulated, and one of them is collaboration and knowledge transfer. So now we should appreciate that health is a global concern, because the people travel across the continents and across the countries. And so it is a concern for the whole planet. So we have to have a strategy which will cover the whole of the planet. So collaborations between the countries and collaborations between the healthcare information systems is important, and they have to integrate with each other. They have to interoperate with each other. So it is a concern for the whole planet. If Elon Musk has his way and we populate the Mars, then we can say that it will also become an interplanetary concern. And digital strategy implementation is the second specific objective. And the third specific objective is digital health governance and the human-centered health systems. That means it should be the patient-centric or citizen-centric healthcare system. So this will ultimately lead to healthier populations. So World Health Organization and the ITU, International Telecommunications Union, have developed a strategy toolkit which will help various countries to formulate their own national digital health programs. And this national e-health vision should respond to the health and development goals of the countries. And national e-health action plans should reflect the country's priorities. And there should also be a plan to monitor the implementation and manage associated risks. So all these are available in a document whose link is given. Most of these, all these documents are readily and easily available on the website, and these links, I have given the links wherever I have been mentioning this. So now, in fact, we have already formulated our national health policy in 2017, and the major features of that are that a national digital health authority will be set up to regulate, develop, and deploy digital health across the continuum of care, and extensive deployment of digital tools for improving efficiency and outcome of the healthcare system. And the policy aims at an integrated health information system which serves the needs of all stakeholders and improves efficiency, transparency, and citizen experience, and delivery of better health outcomes in terms of access, quality, affordability, lowering of disease burden, and efficient monitoring of health entitlements to citizens. And that is the goal. And another important objective was to establish a federated, I think here the federated word is important, national health information architecture to roll out and link systems across public and private health providers at state and national levels, consistent with MDDS, that is metadata and data standards, and electronic health records will be supported by this policy. I think the word federated is important because our country is a federation and federation of states, and health is a state subject. But if we have to have a continuum of care, there has to be some central agency which has to coordinate the healthcare across the boundaries of the states. So this federated national health information system becomes very important in our setup. And we not only have to take along the stakeholders, which are the state governments, and also the private players, because they play a very important role in healthcare, in providing healthcare, and also in creating the healthcare information systems. So the Ministry of Health and Family Welfare has set up a committee under Mr. J. Satyanarayana, the then secretary, and that committee has developed a blueprint. And again, I want to reiterate, this is one of the best blueprints that I have come across. And I'm quite elated to keep reading this again and again, because this is very well thought of and very well conceived document. And if it is possible, all of you should have a look at that.
Shariff, if I can just come in for a second.
Yeah, sure.
The word federated you used, is it the same connotation as cooperative federalism as has been adopted, which is a flexible relationship between the state and the central governments in which both work together in a cohesive manner on a variety of issues and programs, including the National Digital Health Mission?
Yeah, but here it has got a more restricted meaning, because federation means, like, for example, the data may be present in multiple places, but it has to flow. without any boundaries. There should be a seamless integration of healthcare information systems between different organizations, different states and different governments, and that is a kind of that is a restricted connotation.
So when you mention stakeholders, it has the central government, it has the hospitals and clinics, labs, policymakers, providers, admin, allied private entities, it has NGOs.
Yeah, software developers, appliance manufacturers, OEMs, everybody.
Sure.
Okay. So this National Digital Health Blueprint is a 5-layered system, architectural building blocks, and one of the main things is identification. The unique health identifier is actually the thread which connects the patients wherever, even if they are visiting different geographically and temporally separated healthcare institutions. And healthcare information is very important personal information, and privacy and consent to obtain and to use this information is very important. So this is one of the major components of this national digital blueprint. And electronic health record, that is the health record of the patients, which may have multiple visits to multiple healthcare providers, and the data has to be collated into one electronic health record, and that should be available to the patient, and it should be available wherever that particular patient goes, and any healthcare provider should be able to access that electronic health record with the patient's consent. And now, if systems have to integrate and interoperate, the standards are very important. And if the government has prescribed the standards that need to be followed by varied healthcare information systems, so all the applicable standards have to be observed, and the regulations which are formulated by the government from time to time have to be followed. And now
that you mention consent, which becomes a very crucial component of this entire paradigm.
Yeah.
There is, if you can address it now, because as per the document, the Digital Health Mission envisages an automated consent manager instead of a human one. So would you want to elaborate on an automated consent manager?
Yeah, I'll just in a while, I'll just try to talk about that. Okay. So I'll tell you exactly how that is being implemented.
Sure.
Okay. And health analytics, this health analytics is very important if we want to evaluate the healthcare delivery systems, and then we want to plan and allocate appropriate resources, and even for predictive planning of allocation of resources, and then even to evaluate the quality of care. All these kind of things, healthcare analytics become important, and they are also important in big data analytics and application of artificial intelligence and machine learning for predictive for research and other purposes. So once we have data in a very federated environment, we will end up with a large quantities of data which will be very amenable to analysis using the machine learning tools and artificial intelligence. And there have to be multiple access channels, because ultimately the citizen should be able to access this information and all the healthcare resources using multiple modalities, like mobile apps and portals and call centers and all those things. And at this time, we should also keep in mind about providing access to the people who may not have the digital resources like mobile phones and computers, etc. I think that is a challenge, and for that also the systems have to be designed and built. So the core requirements of National Digital Health Blueprint is unique and reliable identification of the patients, trustworthiness of the data, capability of creation of a longitudinal electronic health record for every individual, management of the consent, and alignment with the India enterprise architecture for the national digital health ecosystem. So we will elaborate on this. Maybe at this stage, I can talk about management of the consent. Here, the clear ownership of the healthcare data lies with the patient. Patient is the owner of the healthcare data, and her consent is required if we want to access or use that data in any way. So there is a separate module for management of the consent, and the healthcare organizations or the healthcare providers who are generating the data are merely the custodians of the data. So all the healthcare information about a patient will lie in the custody of the institution or the healthcare provider who is generating the data, and he is responsible for the privacy, the security, and being and that particular healthcare provider should be able to share the data with any other healthcare provider where the patient happens to go, and he or she gives consent to use her EHR in that particular organization. So this responsibility lies with the healthcare provider who is actually holding the data. So most of the data actually is held by the healthcare providers, and this is one common misconception I think that many people have, is that all the healthcare data is going to go into a central repository. That is not the case. So management of the consent, generally, I think one of the ways which we can think of managing is that if a patient goes to a particular healthcare provider and he or she wants that healthcare provider to know their electronic health record, then so that data will be collected from all the healthcare providers that the patient has previously visited. So that means the EHR will merely have the links, and those links will actually fetch the data from multiple healthcare providers when the consent is given by the patient. So I think that satisfies, Nalin, how consent is
I think
managed.
that's perfect, because we have taken care of the patient data, which includes everything from prescriptions to diagnostics, to images, to reports. Everything. And in addition, it is governed by the IT Act 2000, if I'm not mistaken.
Yes.
Regulated by that.
Yes.
So I think we, right. Thank you.
Okay. So these are all multiple layers where this National Digital Health Blueprint it has got the basic vision and the principles at the core, and then there are building blocks around that, and those building blocks have a federated architecture like I mentioned earlier, and then there are standards and regulations, because without standards then the systems where different systems will not be able to talk to each other. And then there are reusable applications. The core applications are actually going to be prototyped and provided by the government agencies, and special applications which will cater to the needs of the healthcare providers will be developed by independent players, who will follow all these rules of integration and interoperability. And then there are services, and then there has to be some institutional structure which will actually implement and enforce this kind of beautifully made blueprint. So these are the various principles. That is the domain principle. That means the principles which will govern the healthcare domain, and then there are technology principles. So the owner of these domain principles, that is the healthcare principles, are the healthcare providers and the experts and the professionals, whereas the technology principles are actually owned by the technology providers, who will actually cater to the requirements of the domain professionals. So I think some of these principles are self-explanatory. They have to, all these things, they have to educate and empower the citizen. That is, the citizen should be aware of what this ecosystem means, and they should be able to choose whether they want to use and which parts of the ecosystem they want to use. So it will be, it's not that we we will not keep the citizens and the patients ignorant and then try to get them to use any parts of this ecosystem.
So basically what you're saying is the domain principle makes sure that it is wellness centric and wellness driven.
Yes. And it's a kind of, the patient is well informed of what exactly he is getting into, what exactly he is using, and how his information will be used.
So that is envisaged. They have already said that it's going to educate and empower individuals to avail a wide range of health and wellness services.
Yeah. And it has to be universally inclusive. That is, we should be able to include even the people who do not have access and the resources to access these digital things. So that is also there. And security and privacy has to be by design. The systems have to be designed. Security cannot be retrofitted. That means the existing systems may or may not need the security and meet the security and privacy requirements of this. So that is why existing digital resources and information systems have to be reassessed, whether they are suitable.
One point that crops up here is when they talk of designed to be, the entire system is designed to be inclusive.
Yeah,
they have probably thought about some specialized systems. How do they reach the unconnected, digitally illiterate, remote, and because that has also been considered, it's not been ignored.
Yeah, that is a challenge. I don't know off the hat if I can only think of remote areas where the internet access is choppy, and I'm not very sure. Probably the information.
Maybe through telephone networks, like if you remember, we devised the telemedicine guidelines for, so that has considered some of these technologies.
Yeah, telephone networks or some other means of, being able to synchronize the data with the systems, nationwide systems from time to time. Probably once in a week, somebody can travel with a hard disk and then synchronize in the nearest district headquarters or something like that.
Yeah. Because while you were discussing the automated consent manager and privacy issues, Ravi Shankar had a question on privacy, which I think has been answered. Because to ensure security and privacy of the patient data information is part of the design.
Yes, it is part of the design.
Policy on security of health system and privacy of hospital.
Nobody can access the data without the consent of the patient. No one, not even the government.
All right, thank you.
So sorry, that was not the question, Nalin and Sharif. The actual question was, when you have systems that need to talk to each other and data gets transferred from one system to another, that is the weak point for someone to hack.
All right. Okay.
So how do you prevent that from happening? I mean, the fact that data is private is not in question.
So you are asking about the vulnerability of the interoperability.
Correct.
All right. Okay.
Absolutely.
I'll try to explain it in very simple terms. Now, the networks over which this data is traveling are all secure networks. The data is encrypted. So, and that can only be decrypted at the ends. So there is no man in the middle attack is not possible because they are all secure communications.
Fantastic.
So that's what now we don't have dedicated networks. Now the secure information is actually transmitted securely over the open networks. And all this happens through what are known as APIs, the application programming interface. And all the software will actually publish the APIs, which they will actually consume and respond to. So now these APIs are all standardized, and then the blueprint itself gives the specifications for all these APIs. If suppose somebody is designing a healthcare information system, they will have to actually publish the APIs using which some other healthcare information system can communicate with this system. And those APIs will be able to fetch the information only if there is consent available. And that information travels in an encrypted format. I think that answers Ravi's this thing.
Yeah, I think that covers it. Encryption is the key.
Yeah, encryption is the key. And then, yeah, performance accountability and all these kind of things. It is possible right now when there is no digital system. We don't even know how these healthcare professionals and healthcare institutions are performing. So once this data is available, it will be possible for us to actually do some kind of a quality control, and checks and balances can be implemented there.
Is that where the India Enterprise Architecture Framework comes in? Part of the technology?
India Enterprise Architecture Framework is on the technology side. Okay, and it is like things should not depend on the infrastructure underlying this. For example, the hardware, the computers, the servers, and the network, and all those things should not affect. So that means they advocate that the systems should be open and they should not be proprietary.
Oh, open standards.
Yeah, all open standards. Yes.
So that helps the interoperability also.
Yes.
Perfect.
Yeah. So I think these two, domain principles and technology principles, are very well addressed in this particular blueprint. And this is a kind of a very bird's eye view architecture like this. So at one end, we have the national level, and at the other end, we have the citizen. Citizen is actually the most important component of this particular system. And if the citizen doesn't participate in this particular ecosystem, the ecosystem will not exist. Okay, so now what is happening at the national level? Now all these small blocks that you can see here, all these are same in all. That is the basic infrastructure. By infrastructure, we mean the computers, the servers, the network switches, the network, and the hardware, and all those kind of things. And over that, we have data. And then there are different technologies. And then there are applications. Applications are the software which are actually accessing. And what technologies do those applications use to access the data? Data generally resides in databases. The databases are relational database management systems like Oracle and Microsoft database or whatever kind of things. And then for clinical data, which is loosely structured, these databases are not very useful. So there is a new crop of databases which are known as NoSQL databases like MongoDB and all those things. And those databases are good for holding unstructured data, which is generally the clinical information. And those databases are also very amenable to big data analytics using artificial intelligence and machine learning, etc. So now those guidelines are also encompassed in this particular National Digital Health Blueprint. So now what information is stored at the national level? It's all minimum information. That is the UHID, and then probably the UHID linking the person with using the Aadhaar number or some driving license or something like that. So that kind of minimalist data. So it's only demographic data is stored at the national level, and at the state level also similarly, whatever the state is using, and the minimalist data which is required for implementation of these statewide health programs, etc. Only that is there. And the local facility stores all the data that is generated by that facility. And this local facility, that data, as and when required, will have to pass through the exchanges which are maintained by the states and the national level, because if the other local facilities will not be able to directly connect with other local facilities. So if one healthcare facility wants to access a patient's data who has come to them, they will have to go through the data exchanges which are maintained at the national and the state level. So I hope how the data travels is clear.
So if I can rephrase that, the process of rigid validation will be applied at all mandatory fields.
Yes.
And at every level, at the state.
Yes.
Fantastic.
And every time the consent is checked, whether there is consent to pass on that data or not is checked for every bit of data.
So that's ownership and responsibilities will be defined at all core databases.
Yes. sometimes the local facilities may not have the infrastructure to store the data and to cater to all these requirements of exchange of data. In that case, there may be some service providers who will actually provide such services for smaller facilities, healthcare facilities, and those are called data fiduciaries. And they also have the same responsibilities about the maintenance of the privacy and security and management of the consent and all those kind of things. Like, for example, a physician who is practicing in some remote village may not have the necessary infrastructure. He may just have access to the internet, and he can use cloud services which are being provided by some data fiduciaries. Okay. Again, these are the various layers. Now, if you from the bottom, that is a layer 1, that is basic infrastructure. The layer 2 is data hubs. Layer 3 is technology building blocks. And layer 4 is application. Application means the software which is accessing the data. And finally, the top layer, the layer 5, is the access and delivery to the citizen. So what are the things that are there in the infrastructure? That is, we have the clouds, health clouds. So we will talk something about the clouds if somebody is interested and who wants to implement this kind of, get onto this ecosystem at an institutional level. We can talk about that later. The health clouds can be, the local clouds are on-premises clouds or off-premises clouds. So they will contain all the data, and there are secure health networks, that is, which are connecting one data center with the other data centers or the other users or other facilities. And there are security and privacy operation center. It is in these security and privacy operation centers that all this consent and security and everything is taken care of.
Sharif, there's one little question I wanted to pop in now, very relevant. Ravi has asked that he says when patients walk in our country to pharmacies and so the relevant patient data which refers to their drug allergies and maybe some medication that they require and the necessary lab test reports, would that be accessible to the pharmacy so that
whatever data is allowed to be accessed by the pharmacist will be given,
and whatever the patient wishes to share?
No, the patient will not be able to share with somebody who is not authorized to see the data.
Okay.
If it is a doctor, then whatever data is relevant, it is the APIs. It is now doctor's application or the doctor's, the screen will be different from a pharmacist's screen. Okay, when the pharmacist actually accesses the patient's data using his OTP or whatever, only the relevant data which is supposed to be useful for the pharmacist will be allowed to be given.
So in that, probably drug allergies, etc., would be included.
Yeah, whatever is relevant. It depends on the application that the pharmacist is using.
Got it.
Okay. So all these, data hubs which are maintained by the governments will take care of the unique health identifiers and the electronic health records and the health master directories. That is, these directories are directories of healthcare professionals, directories of healthcare institutions, directories of pharmaceuticals, whatever kind of things. These are all these are maintained in the data hubs which are actually under the control of the governments.
So that's all the registries and the master database.
Yes, it is under control of the governments.
What do you mean when you say that it is built as a single source of truth?
Yeah, it is a single. Now all these registries are not replicated anywhere. They are kept only in one place.
Okay.
So now if anybody wants to know about a particular healthcare professional or a healthcare organization or whatever, they will ultimately have to fetch that from only that particular source, which may be maintained by the government of India. So there is no replication. Whenever there is a replication, there is a likelihood of data corruption or whatever kind of, the quality of the data will suffer. And these directories are populated following verifications. which are done by the professional bodies like the National Medical Commission or appropriate bodies which are supposed to verify and authenticate the credentials of those particular healthcare organizations or healthcare professionals or whatever. So that is why that data is reliable and it is highly dependable. And it is maintained in only one place, which is not the case right now. For example, medical councils, state medical councils maintain the registry of the doctors, and those are not updated till 5 years or something like that. In the meantime, if somebody is transferred or if they are disqualified or whatever kind of things, so that data is not updated. So these things will happen promptly once this ecosystem is fully implemented.
And where does insurance marry up with this particular system? Because there's a concern that this information may be abused by insurance companies.
Information of the professional?
Patient information and their, this stuff.
No, they will not be able to. They will not be able to abuse the information because the information will be provided to them only when they are authenticated by the patient.
So I hope that satisfies Ilango.
And they cannot even fudge the information because the systems maintain a log of every key press. Suppose you are accessing a patient's record and that record was created by some other doctor, and you will not be able to change anything, even a single letter of that information.
Thank you.
Because logs of every change is maintained, and there is something called versioning in that. If at all there is any change, all the previous versions also will be maintained. And it will also record who is making which change at what time. Okay, so the technology building blocks may be health locker. For example, like I think everybody is aware of those DigiLocker, where you can store your driving license, Aadhaar card, or certificates, or those kind of things. So health lockers will be provided, and there will be anonymizers. For example, anonymized data may be used for big data analytics and applications using AI and ML and all those things. So supposing we have permission to use anonymized or de-identified data of the patients, as happens when we do some research projects, etc. So anonymizers will be there, and they will actually anonymize the data, and then they will provide to the researchers or whoever requires that. For example, the country healthcare policy planners or whatever kind of things. And then there are modules which are called consent manager, which will do that management of the consent. And then there are health analytics, again, for policy planning or for research. And then there may be visualizations. That is, when we have large amounts of data, just visualizing the data will give us some clues of what is happening to the health scenario of the country or something like that. And depending on if we also have the GIS information tagged with that, we will also know the geographical location of the healthcare problems and where we may need to allocate our resources or whatever kind of things. And then the health information exchange, self-explanatory. No. So these are these exchanges will actually pass data from one place to the other, and they don't hold any data. So application building blocks are all these, these programs, the software that we use for, for emergency care, healthcare applications, wellness applications, medical education applications, and public health applications, and all those things. That is one layer, that is application building block layer 4. And then how the patients access and how the healthcare services are delivered. So those are the apps. They can be mobile apps and portals, web portals, or they may be using social media or call centers. So call centers may be one of the methods of catering to the people who don't have the digital resources like smartphones or computers or access to the internet. So call centers will be able to access the data, and then again they will also be bound by all the privacy and security and all those kind of things. So secure health networks, yes, this is a very important thing. I think everybody is worried about the data being secure when it is traveling on the network. So I think everybody is aware of these virtual private networks. So such networks may be established if there are large volumes of data traveling. For example, at AIIMS, now we have all our servers and data centers in the main AIIMS, and we have satellite centers in Ghaziabad and in Jhajjar and all those things. Actually, the data travels from here. So we have dedicated lines which are actually tunneling through the internet. So nobody else is aware that this data is actually traveling. All the people who are on the internet are not even aware that data is flowing between one center of AIIMS and the other center. And then I think the government is also setting up what is known as a health cloud. So, and it is recommended that any of the healthcare organizations or professionals who want to avail cloud services may actually trust their data on these health clouds. So Security and Privacy Operations Center will take care of all the security and privacy concerns. And these are all maintained by the governments and generally by the Government of India.
So when you say government, there was one question that had come up, which I found very intriguing. If there's a change in guard, change in governments, and does anything get affected at all?
No, there are checks and balances. Even the government is considered as a third party. The government does not have a right to access anybody's healthcare information. And these systems will ensure that nobody can access without the consent.
Amit, I hope that satisfies you.
No, but then they're all humans. No, if somebody, if somebody puts a gun to the head of the admin and says that you give me this data, then nobody can help.
All right. So we'll keep that aside for the moment. Please.
Yeah. Because somebody will be able to access this, isn't it?
Yeah.
Yeah. This is the kind of things. Now, on the left of this, the networks, this was the earlier scenario. They were all silos. You know, there were doctors and nurses, and there was a platform, and then the patients were accessing, and they don't talk to each other. Okay, and for this you require a particular application, and this is a different system, and there are 3 different systems which don't talk to each other. Whereas on the right side, you can see that there is a common network. All the information is flowing through this, and multiple applications are on one side of the network, and the other side where the citizens, patients are accessing that, they can access any services from anywhere. And this is the kind of architecture, which is open network centric model. And these, you know, generally nowadays they use what is known as microservices architectures. There are small software applications which are built for specific purposes, and those will actually keep talking to each other through what are known as the APIs. The APIs are the application programming interfaces.
All this infrastructure is going to be very, very finance intensive. And just so that there were a couple of concerns about the amount that would be required, the National Health Mission has huge amounts already.
No, not exactly. Not exactly. Though these things are sounding so big, the infrastructure that is required at the government level, central government and state government level, is not so high.
Now, why I mention this is because even in Shillong or in Meghalaya, where I am, and also I'm aware about Arunachal, I'm aware about Nagaland and Mizoram, and even Manipur.
Yeah.
Infrastructure, I mean, the government has already provided. The NHS.
Yeah, the government has already provided. I think there are.
We have a very dedicated and a robust system here. So I think it's a very creditable job.
Government of India has already sanctioned about 1,600 crores over the next 5 years. And most of this infrastructure at the government level is already in place. And you know, the Ministry of Information Technology and Electronics and Information Technology has already put most of these things in place.
No, I have it in my institution, so I can say if it's here in the northeastern region,
yeah,
we are doing very well.
Yeah. See, the thing is now these things are centralized and they can be accessed from anywhere. So that is a good thing about, you know, these cloud technologies and, you know, data centers on the cloud. So you require very minimal, infrastructure at the peripheral parts of the network. unless the healthcare provider organization is huge. And if the transactional data is very voluminous, they cannot rely on the cloud. So they will have to either have on-premises and off-premises, a kind of a hybrid cloud architecture or something like that. So the key entities in all this, the ecosystem are the person, the care professional, the care providers, payer, that is those insurance and other people, governing bodies, research bodies, and the pharmaceuticals. These are all the key entities or the stakeholders. So the directories are the facilities directory, that is healthcare facilities, the doctors directories, nurses and paramedical directories, health workers directories, and allied professionals directories. These are all various directories which have to be populated. They started off with the doctors directories in some of the union territories, and they have recently announced that the nurses directory is also open now, and all these enrollment in all these directories is voluntary. And they also want to have directories for the Ayush, professionals.
Professionals are part of the doctor directory. It has been Ayush has been included.
Yeah. And so far, I think there was no such directory. They were not included in anything. And this is the first time that we are having a directory for the allied other healthcare systems.
Sumant, you want to come in here?
Yeah, I thought maybe once Dr. Shariff finishes, I thought I would make a few points. Essentially, there are a lot of concerns about the system, and I have a long list which I thought I'd go through. So maybe once Dr. Shariff finishes, I could just have about 3-4 minutes to sort of explain those concerns.
So I think all these layers will keep on dealing with the various things. Some of these applications which are managed by the government, and then most of the other applications will be actually produced and managed by the private sector. Healthcare software developers and systems integrators. So some of these government managed health applications are these government schemes, reproductive and child health and all these kind of schemes. And then access can be through call centers, the health portals, web portals, social media, and mobile applications. And it is recommended that everything should be mobile first. The approach should be mobile first. So any patient or any citizen should be able to access all these resources using just a mobile phone. And then all these online education apps and voice-based services, that is the IVRS systems, all those things should be able to access these resources and the electronic health records or whatever. So interoperability is the key, and they will have to use the India enterprise framework, and it should be agnostic to the underlying infrastructure, and it should be a federated architecture. Semantic and syntactic interoperability has to be there. Semantic is meaning-based, interoperability. Suppose there are some terminologies which mean the same, but the terms are different. The systems should be able to, that is the advantage of using artificial intelligence and neural networks and all those things. That is natural language processing and other kind of technologies may be used for finding semantic similarities. And some of these standards which they have prescribed, and all the systems should be compliant with these standards. FHIR is the latest version of the HL7. This is the version 4 of the HL7. HL7 is a very common format whereby the healthcare systems talk to each other, whether it is diagnostic equipment or some kind of machinery which is outputting data or accepting data. They all accept or output the data in the HL7 format, and the latest version is FHIR, and the National Digital Health Blueprint recommends that the systems should use FHIR. Dicom is a very common digital image and communication format, which is used by all the CT scans and MRIs and all the other imaging modalities. SNOMED CT has been this thing for the clinical terms. It is a systematized nomenclature for medicine, and it is recommended that SNOMED CT should be used in all these healthcare systems. And ICD-10 LOINC is again lab equipment. They use this format for data interchange, and other image formats like JPEG, PDFs, and for video and other multimedia image formats like MP3 and MP4. These are all recommended standards which have to be used by the healthcare systems, and all the systems have to be compliant with that.
ICD-10 has been made mandatory for now just about every hospital, including
ICD-10 is mandatory, yes. Again, so for security also they have prescribed the standards. So for security, access control, and immutability, and versioning and non-repudiation, that is, any record that is created must be traceable to its creator unambiguously. So any record, you can trace the creator of that record. Audit log, that is, any modification or amendment or any change is logged. So even one key press, one letter change also will be logged. And the patient will be able to access or view his own health records anytime and control the access by others. I think this is a very important line. It is, patient is the master. He is the owner of the data. He can see his data anytime and he can decide whom he wants to show. So institutional setup was recommended by this National Digital Health Blueprint, and that institutional setup is the National Digital Health Mission, because this whole thing has to be implemented in a mission mode. And so they have created this as a kind of a semi-autonomous body under the government, and it has sufficient powers, financial powers and regulatory powers and all those things. And in the course of time, it is envisioned that this will actually metamorphose into National Digital Health Authority. So there is a National Health Authority now, and we are talking about the National Digital Health Authority. So now these are the responsibilities of the National Digital Health Mission, that is National Health Electronic Registries, Federated Electronic Health Record Framework, National Health Analytics Platform, and they will have to take care of all these things. They have to design, implement, and manage, maintain all these things. And then other horizontal components which will be used across the systems, that is UHID will be used across all the systems, and health data dictionaries, that is the definitions of the data which are being used in the healthcare systems, information exchanges, the gateways, the supply chain management of whatever components, drugs or equipments or whatever kind of things. And they should also enable and facilitate. They enable by actually being able to design and create the core components, and they should also support the private and other stakeholders in actually developing the healthcare information systems. So these are all the responsibilities of the National Digital Health Mission. And again, I think we have discussed enough about the federated health identification that is based on Aadhaar and all those things. And DigiDoctor platform, that means any patient will be able to access any doctor. Once the doctor is enrolled in the directory, if he's there, that is they're accessible to any patient. So probably that is one of the advantages for the doctors to enroll in these registries.
Now, when you talk of the National Digital Health Blueprint,
yeah,
they also have one mandate that researchers will benefit from this aggregated information.
Yes, that is, de-identified data, anonymized data will be made available to the researchers.
And they want a comprehensive feedback between researchers, policymakers, and the providers, so that
yes,
the evaluation of the entire system can take place.
Yeah, that is when we have sufficient data and data of good quality. I think one of the weak links in this whole chain is the inputting of the data into the systems. We are talking of situation where the data is there in the system. I think the biggest bottleneck is at the point of entry of the data into the system.
But I think that has been addressed partly because if you remember the telemedicine guidelines we formulated, it was mandatory that within a specified period of time, all the registered medical practitioners would be trained, and they have to undergo a course and assessment to be, on the same page.
Yeah. Anyway, we have to avoid some innovative methods of actually putting the data into the systems, because this particular aspect only has led to burnout in all the Western countries, because the doctors are spending more time with the computers and less time with the doctors. I think Amit and Ravi can vouch for that. This is a very interesting thing. There is an NDHM sandbox. They have implemented what is known as a sandbox. If somebody creates a healthcare information system, they should try it out with this sandbox. This sandbox gives all the APIs and all the interoperability and integration facilities. So if it is fully compliant with this, that is, if they can enter the sandbox and then do whatever business they want to do, and they can exit the sandbox, that means their system is fully compliant with the National Digital Health Blueprint. So this is of interest to the developers of the healthcare information systems. And this it also allows this alpha testing and beta testing of the information systems. So once it is fully compliant with the sandbox, the developer can be satisfied that their system is secure, and it can integrate with other systems, it can interoperate with other systems, it will manage all the privacy and the consent and everything. I think
quality check.
Yeah. Nalin?
That's a quality check kind of a thing.
Not just quality check, it is a complete interface. It is as if the sandbox is another distinct application with which your application has to talk. And it will test all aspects of your application, including the security and all those kind of things. And that means all your APIs, the application programming interface, is working as claimed.
Lovely.
Yeah, this is just of academic interest. This is the organogram of the, and now this National Digital Health Mission was actually renamed as the Ayushman Bharat Digital Mission. And this has been launched by our Prime Minister on the 27th of September 2021. So now this is working, and many doctors and professionals from many of the union territories have already been registered in the registries, and nursing registry has already started. Now, if you want to register, these are the websites. The healthid.ndhm.gov.in register. So we can create this Ayushman Bharat health account number. That is, the unique identifier is called the ABHA number. So it is possible for healthcare professionals to register. It is possible for patients to register on this website. So I've just given some of the screenshots of these websites, and this is for the health facility registry. So you have to generate a healthcare professional ID for yourself first, and then search for your facility, because if the information about your facility is already existing in the systems, that will be fetched for you. And then you have to fill the registration form, which will give the details of your facility, and then ultimately you submit. So this is how you can register. So on this website of the NDHM, one can register and get an ABHA, and also register their professional, they can also get their professional ID and also register their healthcare facilities. And there are most of the questions that have been asked here are already answered in the FAQs of this Ayushman Bharat Digital Mission. So I think you may try.
Yes.
Now I just wanted to share a few of our these things, whatever we have done at AIIMS. So some pictures I'll show you. This is our dissection hall. So our dissection hall is digitally enabled. You can see that the systems are hanging from the ceiling, and in that we show whatever dissection, briefing, debriefing, videos, and the specific learning objectives and whatever things this particular group wants to access, they can access. Each of them is a smart station. And they are accessed using wireless keyboards and mouse by the table teachers. This is our digital histology laboratory, which Dr. Radhakrishna was mentioning. And every student has their own workstation, and there is a teacher's workstation. And whatever the teacher wants to show under the microscope, that appears on the student's workstation. Two-way communication is possible between the teacher and the student. And we have also provided the microscopes to the students so that they can have a feel of the actual slides and observing them under the microscope. Because I did not want to be the one to kill the existing technology. I thought that the existing technology should survive as long as it can. So let it die its own natural death, and I didn't want to be the one to put an end to that. So now we have a kind of a hybrid, the old traditional system as well as the digital systems here. I think these people are actually giving a quiz at this time. This is the teacher station, and we also have a touch sensitive large screen here, and whatever we write or whatever we do here is also visible on every student's workstation. This is a first of its kind laboratory in the country, probably in Asia, and many healthcare professionals from advanced countries have come and appreciated this, and they have taken pictures. So you won't believe, people from Germany and Japan also have come and taken pictures of this, of our lab. And the best part is that no company was involved in establishing this lab. This was totally conceived, executed, designed, implemented in-house. I myself, with the help of 2 of my technicians, we have done this whole thing.
Including your own servers.
Yeah, my own servers. We run our own servers. My departmental network was a 10G network, and it was the first 10G network in the country. Not even the IITs and those things had. That I established in 2008 or 9. And right now we have the largest local area network in the country at AIIMS. We have 25,000 nodes, and it has got a 100 gigabit backbone. Again, that network also has been conceptualized, designed, and implemented by us, and all our new blocks, OPD blocks, surgical specialties blocks, and mother and child, all these blocks are connected by a 100 gigabit backbone. And it is a dual redundant connection. Even if one connection fails, the user will not even know. I think Nalin is aware of that particular network in all the new blocks. And this is our Jugaad e-learning resource material studio, which we made in the dissection hall. And you can see that green chroma key behind there. And there is a high resolution camera on top hanging. And this is a modified OT light. I just removed the OT light and put a high resolution camera there on top. And there is a camera in front, which will actually show the teacher. So both we can do. And we use all free and open source software for doing all these things. And this is what is known as a simulation, e-learning, and telemedicine facility. We have all these mannequins and all the digital learning systems, endoscopy simulators, all those kind of things there. I don't know if Dr. Radhakrishna has visited. If any of you happen to visit AIIMS, please come and have a look at all these places. These are some of the first facilities in the country. We also have a e-learning management system, which is implemented using, again, free and open source software, which is known as Moodle. Many of you may be aware, may have heard about this particular modular open dynamic learning environment. So this is called Saral, and on this we do course management, and student management is also done on this. That is all their results and exams and everything is managed on this, right from the time of admission till they pass out.
Ravi had a question. How do you make uniform digital slides?
Uniform digital
slides, the slide histopath slides, etc. I presume that you have shown in the class, in your laboratory.
Yeah. So we have our research microscopes with high resolution cameras, and we also have whole slide scanners nowadays. Okay. We can just put a slide and scan the whole of the section.
So it's not machine learning or AI generated stuff.
No, no, no. They are not AI generated. They are captured from the real sections.
So Sharif, quick question. The reason why I'm asking that is that, when you look at slides from multiple labs, the digital images don't have the same quality.
Yes.
Because, if you can make digital images uniform, then it'll be so much faster to get central reads, because all you have to do is just transmit the digital images, and in a matter of minutes the person can get it. Right now, most of these central readers are requiring samples to be sent to them so that they can acquire their own digital images, because the images are not uniform, especially if you're looking at images coming from labs across the world. So that was one of the big reasons why I asked, like, how do you sort of make the digital image quality uniform? That was one question. And the second question was, like, when you read these slides, have you started using AI or artificial intelligence or machine learning techniques to read slides once you digitize them?
Actually, we are not in anatomy. We don't do diagnostics. So we are not using in pathology on experimental basis. They are doing some studies.
Can I add
using
to
the
that?
AI and artificial neural networks? And again, image quality and uniformity is a problem.
You have just to add a point. You can use Dicom imaging for slides. I think it's called whole slide imaging using Dicom.
Yeah.
So you can use the same Dicom standards that you use for radiology images for histology. That is now sort of, in the last 2 to 3 years, it's sort of becoming the standard for want of any other standard at the moment. And running machine learning algorithms is also sort of, there are also a few open source systems which are available where if you want to sort of, algorithms where if you want to get your feet wet, I mean, they're not at this point of time absolutely perfect. But if you just want to figure out what's happening, you can find open source algorithms which you can try, and just to understand how this would eventually work.
But I think Dicoms are standards where different machines talk to each other. They are not, I mean, they're not some sort of a standard.
Dicom is basically
it's just an intercommunication between various.
No, sir. Just one correction. See, essentially, what is a Dicom image? A Dicom image is where every component of the image has a particular value which is assigned to it in the form of a metadata. So when you actually, I put it in a simple way, if you want to see, if you're looking at, let's say, a simple chest X-ray, and there has been a overexposure of one image in one system, and the other system is normal or whatever, from the grayscale value on that particular pixel of the image, which is captured by the Dicom, in a Dicom image, you will be able to know that a hyper intensity is actually because of a technical problem and not because the image is really, because there is a pathology there. So basically, every attribute of every segment of the image is captured in the form of metadata, and that is why a Dicom image which is transmitted can be easily compared. And when you have any doubts, all you need to do is to go and see the Dicom, what are called Dicom tags, which is essentially the area where the data is stored. And you look at the data and you say that this is the reason why this image shows a particular pathology. So you can actually, the transmission part is not really the core component part of the Dicom. It is essentially defining the attributes of every pixel of the image.
Well, that is the technology component, but Dicom essentially is an international standard format. Whether you want to view, share, report, whatever you want to do. So it basically goes around. So it is required that you follow an established international format, which you may view, you may share, but so you mentioned the underlying technology, which I presume is pretty robust. As of now, we just have that.
Yeah, ultimately, Dicom is a kind of a wrapper. Ultimately, what matters is the bitmap, the image as it is displayed. And now, as if there is some error in the image, Dicom or anything is not going to correct it. If there are
Sir, if there is an error in the image, it will be clear to you. When you have a doubt, you go and look at the particular area of the image, and it will tell you that this is of a different grayscale, different intensity, or whatever, and you will know that this image is the error in the image is clearly visible to you. So basically, Dicom, that is the purpose of Dicom, to define each and every pixel in the image.
So that is the technology behind it.
Okay,
but it's basically a complete specification to enable interoperability between the medical imaging systems.
The format,
that is the person, Okay, anyway, I think this is secondary.
But Sumant, you had some more queries which you wanted to ask.
Sir, let me make a few points. First of all, there are...
Sorry to interrupt. Sharif, we finished. Otherwise, could you stop sharing?
I am done. I am done. Thank you.
Can you stop sharing your screen, please? Over to you, Sumant.
Just I'll not take more than 4 or 5 minutes. I just want to make a few points. One of the key challenges here is the entry point of data into the system, as Dr. Shariff pointed out. First, let us understand that this system is not compulsory. It's not mandatory. So there is no law in this country at this point which mandates an electronic medical record. And therefore, use of the system is purely voluntary, which leaves a huge gap, simply because, we have seen from my 20 years work in TCS, which I have actually put in, that where there is no mandatory requirement for electronic medical record, by and large, the healthcare professionals do not tend to use one, or at least certainly not use one which is to be used in the manner that to the extent that it should be used. So in 2012-13, I was part of the National Healthcare Standards Subcommittee. We made a plea to the then government and the then health minister, saying, please make electronic medical records mandatory in India over a 10-year time frame. Sadly, neither the previous government nor the present government has done that. And therefore, whatever else we are doing down the street, I think the first thing that we need to do is to make electronic medical records mandatory in India within a specified time frame, say 10 years or something. Because all of this assumes that data will come into the system, which it may or may not. Second, the very important point is the consent and privacy issues. India does not have a Data Protection Act. So there are serious concerns which have been raised. Now, how many of you already have health records in the system, unique health IDs? Do you know? You may actually already be having it without your knowledge, because what happens is when you went on the COVID app, when you got your COVID vaccine and you went on the COVID app, if you used your Aadhaar, it was in the fine print, you were actually giving deemed consent for having your unique health ID created. So millions of people in India already have health IDs, but they don't know about it because it has been done in this manner. At least educated people use the COVID app on their own, but many people use the providers to actually go and use the COVID app for themselves. In those cases, they were not even aware what the provider has actually submitted in the terms and conditions. So first of all, millions of Indians already have health IDs in the system, except that they don't know about it, right? So which is not a very good way of actually implementing such a system, because consent remains a major concern. The third point, again, which is another massive area of concern, is that once you have consented to the system, to having your data in the system, you have zero say as to what it can be used for and who it can be given to. So the government, the Ayushman Bharat Digital Health Mission, will decide to whom this data can be given to. You have no say. As a patient, you cannot tomorrow say, I withdraw my consent for this particular provider, this data should not be shared. You have no way of saying that. So that is another major concern. The other very significant concern on this is, let us say there has been a data security breach. It can happen in the best systems in the world, and it constantly happens in India with other systems, so it can happen here. The very framework says that the digital health mission should be notified, but not the individual. So your data could be actually taken by somebody, and there can be a breach. There is no legal requirement even to inform you that there has been a breach. So very importantly, let us say your data has gone to, it has been hacked or it has been stolen. There is no legal recourse at all. You can do nothing about it. So for instance, today you want 10 million Aadhaar records. I think the cost right now is around 4,000 or 5,000 rupees. If you haggle, you can even get it for 2,000, 3,000 rupees. So that is the level to which data security and privacy is a concern in India. And unfortunately, this entire conceptualization has not factored in this big fact. It is taking into the old premise that people will trust their doctors, people will trust the government and will part with the data. But these are serious concerns. The other big area, which is a big black hole, is that health is a state subject. It is not the primary subject of the union. It is a state subject. Individual states have got their own systems. For instance, we installed for the Tamil Nadu government, for the Gujarat government, and so on, healthcare information systems which have been functioning for 10 years and so on, where there is millions of patient records are already stored. Now, how are these going to be co-opted into the national framework? Because mind you, legally the states have no obligation to join. I mean, the government can make it difficult for the states to say no.
Yeah.
But let us be clear, legally the government of India cannot mandate the states saying you throw away your system and you have to be on this. We saw this even for Ayushman Bharat, for the insurance scheme itself. We saw it what Bengal and other states did. Bengal said, we don't want your system. We have a better system. We don't want your Ayushman Bharat system. So there is going to be a major issue in terms of deploying the system. These states, by and large, and I have had informal talks with health secretaries in a few states, particularly in the south, and the states are, let me put it in two words. One, they are pretty clueless. Of course, they have seen the PPTs, there have been presentations which have been made and so on, but they are pretty clueless as to what they are expected to do right now, right? And the second part is they are not really sure as to what control the state governments will have once this whole project rolls out. So basically, let's say we take Government General Hospital in Chennai, where the state government has got systems to capture medical record, and they are getting the data from the patient, they are inputting it into the system. Hypothetically, and this is a natural thing, everybody wants to have some control. Now, state governments are saying, what's in it for me? If the state governments are not going to get the credit for the system, they are going to have to make certain investments at the local hospitals. And then this data will go into a centralized database. The other very important point is, there is, I don't remember who did this study, but I think Dr. Srinath Reddy may know about this. There was a study which found that over 97 or 98% of all patients seek healthcare only within their own state. They do not go outside the state to seek healthcare. So there was a big, issue and a question of why do we need, large components of this data to be moved out, except on an on-demand basis. Let us say hypothetically a person from Chennai or from Bangalore goes to Delhi and he has an accident, and on an on-demand basis he's admitted to AIIMS and he needs the data needs to be accessed there. So that's a on-demand situation. So there is no need for this data to actually populate any kind of centralized database. So there are, I mean, I could go on for the next hour on this, but basically to cut a long story short, one is a top-down approach. Second, and in all these systems, technology is never the problem. It is the human element which is the problem, right? I mean, in 21 years, I have never ever come across, even in, when internet connectivity used to be bad and various technological issues used to be there, we were in a primitive era then. Even then, the majority of systems failed because of the human element, because people said they will not enter the data, or they found it too cumbersome, there's no legal requirement for them to do it, and so on. So the same story holds good for breaches of security. The element is not your secure VPN. The element, the weakest element in the chain is that data entry operator who's sitting there with a user ID password, who will probably sell that data for 3,000 rupees with no consequences. So I think that there has to be a serious rethink of how this system is going to be rolled out. Yes, the government has a lot of money which they are ready to spend for this, and they've got a lot of consultants, both from the consulting firms as well as local IT companies, to have given inputs. But having been in this field for 23 years, the lesson that I have learned is, if you want to successfully roll out a healthcare system, it has to be done from the bottom. Once the data comes into the system, you can do anything with it. You can dice and slice it, analyze it, you can put it in silos, you can distribute it here. All of that is a no-brainer, because today we have such wonderful technologies and tools to make all these things happen. But the biggest challenge is, what's in it for me is the question that needs to be answered at every level. What's in it for the doctor who's entering their patient record into the system? What's in it for the patient? Yes, we know the patient is going to have certain benefits, which are clear, but what are the risks of the patient data getting exposed? We have to juxtapose that. But at every level, unless it is a win-win for every stakeholder across the chain, there are, to my knowledge, there is no country, forget countries of India's size, I'm talking about even medium-sized countries or small countries that have implemented healthcare systems successfully without making it mandatory. So if the government is serious about implementing this, they need to bring in a law in Parliament saying that electronic health records will be mandatory for Indians within a period of 5 years, 10 years, whatever. I mean, you have to give a reasonable amount of time. You can't say it as mandatory in 6 months or 1 year. It won't happen. So the issue is, you start there. Then you hold discussions with the state governments on how to make this possible, because they are eventually the ones who are providing that healthcare service. The vast majority of healthcare to the state government is to the people is provided by the state governments, and of course, I mean, I'm talking about in the public sector. So these are a few of the missing elements that have concerned me. In fact, I have spoken about this at at many fora also, where I have said, look, there needs to be some kind of a corrective. Otherwise, what will happen is, we can have millions and millions of records, like for instance through COVID vaccinations, or through various other means of saying, if you submit your Aadhaar somewhere else for some banking transaction, you will get a health ID free of charge or whatever, and you will get zillions of health IDs with people not knowing that their health IDs are there. So it will be possible for the government to claim that 42 crore people are registered on Ayushman Bharat Digital Health Mission, but net there will not be the benefit that we need to actually accrue from such a system. If such a system is successfully implemented, it can potentially transform the quality of healthcare delivery that we have. But the implementation it's all about the implementation. We could design the best technology related systems in the world, but I think that we need to focus much more on this particular aspect. And I sincerely hope that the government would sort of look into these aspects, because I mean, what most failed implementations have happened because of the problems at the last mile and not problems at the top. Problems at the top in terms of the technologies or servers and so on. So those can be sorted out. Getting people to input data is a huge challenge. So and these are a few of the thoughts that I want to share.
Sumant, I appreciate what you said, and not just your concerns. You have inadvertently offered a few solutions, and I'm extremely glad to note that as I can see it in a remote area, along with the state government, we are even into having a good interface with the state government. The National Health Mission has been implemented with very, competent and senior officers just about everywhere, even in slightly areas where you can't reach very easily. Access is limited. So they have included a component of comprehensive primary health care expansion. So the approach is bottom up rather than top down. And the amount that they have invested, in fact, they are using the ASHA workers, they are using just about everybody, and it's a bottom-up approach. So that's where I think when they promote clear steps of regulation of private healthcare, the route for reducing the misuse then probably becomes a lot easier. And since this NHPM is not even more than a year old, I think we should give them a little time. They are working on the right line. They're addressing privacy, they're addressing expansion, they're addressing bottom-up model, and they're training trainers and they're training people in the outreach. So I think overall, I am looking forward to a reasonably good implementation. That having been said, data hacking and somebody selling Aadhaar, all that goes on. But there are very, very strict laws, and they have, all kinds of proper mechanisms have been factored in. Despite that, if something has to go wrong, it probably will, but I think overall things are.
Sir, there is no law, sir. That is the only concern. There is no data protection law in India.
I think that's what I think.
There are no consequences for the sale of data.
That has to be addressed. I think now we can insist on a similar good framework of legal and regulatory things. Actually,
exactly.
They have to put in place first.
Exactly.
Yeah, before they expect all of us to get on board, probably they have to offer this. The privacy and security has to be assured.
And this
data privacy policy in the country.
This concern has been raised at every platform with the Niti Aayog. We were together, if you remember, Sharif, when we brought this up at the NMC.
Yeah.
And it's been taken up with the National Health Mission. We take it up with the health ministers meeting that we had very recently. So that I think is the focus of just about every meeting, and everybody here probably appreciates it too. It is a matter of concern, and we have to have regulations and law to protect.
In fact, before doing anything, we have to have a data protection policy and framework for the entire country for all kinds of documentation before we even step one of this first layer of your program.
Point taken, Pankaj. I think that's very, very right.
Yeah. About your suggestion, Sumant's suggestion of making it mandatory. Our doctors in the OPD get 3 minutes for a patient. In that, they have to take history, examine, and write this thing and give a prescription and do everything. So now, if it is made mandatory, I don't think they will be able to see even half the number of patients.
Sir, then the continuity of care will be lost. See, the problem is we can't have, let us say, 4 episodes about this patient available online, but 3 episodes or 3 encounters that he has had in the OPD is not available. So that is the fundamental. In fact, in Tamil Nadu, we rolled out a system which actually functioned quite effectively in an OPD for about 4 or 5 years, I think. I don't know right now the current status, but about 4 or 5 years it worked quite well, where we would get just the test order, the prescription, and the positive clinical findings in an OPD to be entered in a templatized format in about 45 seconds. But if we do not get at point of care, we get the data into the system, then whatever else happens up the chain, it is going to be incomplete.
But these are concerns that have been flagged by just about everybody in most of the meetings. So I'm sure there are going to be mechanisms factored in to address this.
Maybe we can start off with IPD, if not OPD.
I was just wondering if we've been a little over almost nigh on to 2 hours. So Vidya, would you want to jump in now?
Yeah.
I'd like to thank Sharif one hell of a lot for an absolutely brilliant and a very comprehensive description of this pretty difficult topic to grasp.
Since very important things were being discussed, I thought we'll just I mean, the whole idea of having you guys on board was to get everyone's opinion, the pros and the cons, and the good and the bad. If anyone else wants to make a point or a comment, please feel free. And Amit, you guys have been using electronic health records forever, and let's not go back to the same point that you have half an hour to see a patient, and somebody else has 3 minutes. That is a given, of course. But other than that,
yeah, it's not how or why. It's when is India going to implement it? That's the main question. Here we have strict rules. We use a triangulating system because we see a lot of VIPs. If somebody does not need to see the record of the patient, I mean, is not directly involved with the patient and has opened the chart, we have a security system by triangulation that they have picked out, and we have had to fire several employees. Here we use the EPIC system, which is not a federal system, but that has about 70% of the hospitals in the US are using it. It is causing burnout, no problem. The data management system, as Sharif has said, is an issue, but it has helped me a lot. I would give you an example. As a doctor, I'm a salesperson, and I have to make the pitch for the patient. But if I have nothing to sell, I have nothing in the inventory, nothing to sell, I cannot be a salesperson. The same example is I had to refer a patient, a good friend of mine in a very reputed hospital in Jipmar. I call this most reputed doctor, and he's helpless because he does not have the records. He's working in silos. To take my patient, he has to invest so much time and energy gathering around it. And my patient finally gave up and had to be called by somebody else who had a much more integrated system in India to be taken care of. What you're talking as a physician, if you're a salesperson, the equivalence is trying to be in a company where the shelves are empty. We are the most skilled people in the planet, but have nothing to offer because of the silo system. And as much as we argue as to what the negatives are or positives are, and it's causing burnout and things like that, there are very smart people who, that is what management is, to integrate not the hierarchy of doctors, but use IT and administration, how to work together. This is not doing anybody any favor. I completely agree with Dr. Rahman that it has to be mandatory. We found out when doctors are allowed to do their way, they completely take over. They work as dictators and spoil the system. There's a system of recertification here, and there are doctors who were grandfathered. They had graduated before 1990. They were given the thing about if they wanted, they could recertify. Less than 1% recertified. So I have to recertify because I graduated after 1990 in the US. You have to take the test every 10 years. So like it or not, it has to be mandated. India does not have that. Whether 90% are taken care in the state and 2% go to AIIMS is not the question. The question is, do you value a human life? Is an Indian life, or is your zip code or PIN code where you're born is completely determining your entire life? And even the smartest people sitting out here in the audience have no control about security, are completely submerged under what to do, what not to do, while you can debate, you know what is there in the system. Having said that, I need to congratulate Dr. Sharif that he taught me a lot. He democratized the whole problem by bringing this up. I learned a lot about my system in Mayo Clinic by listening to his presentation. Some interesting conversation going on in the back, but this is a real issue for you. If in India, your leaders in India, you want to compete with the West, compete with UK, share your data. You want to say you're the best in IT. You are the best in IT, I can tell you that. But you have nothing to prove. You have to show something. So argument, as much as it is government, whichever government comes, we have to bite our pride and accept that we are world standard. You are world standard in whatever you're doing, but you have nothing to show. The emperor cannot go on and on and on without any clothes. You have to standardize the practice. You have to be, I have people balking as saying Indian doctors are average, mediocre. Oh, I went to this Indian hospital, this was not there. And I say that's not true. But I cannot say with pride that it is till you show it. You have to break that big, there's a glass ceiling, and break your egos into what can be done and what cannot be done. Can be started as a low, Sharif presented a thing, think big, start small. And that is what we do here also, and go forward. You've got to do it. 2030 is a good time to think about all these things, but you got to do it. You've got all the platform. Dr. Raman has the platform. Nalin Mehta has the platform. If now, when? That would be my say. Please do it.
Very well said.
Can I add something?
Yeah.
So I just wanted to say that just like Amit just talked about the usefulness of such a system in terms of clinical care, it's probably even more important from a research perspective. Having these standardized electronic medical records, I think, is basically the secret, if you will, for the GPRD database in the UK and the Kaiser Permanente database. Now, the amount of data that's coming out of these databases is simply enormous. But what is even more stunning is the amount of money they are making by selling de-identified data to people who want to mine that data and come up with their own and answer their own research questions. So it's not just the fact that you have the data and you can analyze your data. You can also generate revenue by using de-identified data. That is something that is a model that's worked beautifully for both the GPRD databases as well as the Kaiser Permanente databases here. And so I would seriously suggest that people think about that as well when you set up these things.
Right.
Good point.
So, so Sumant, you had to bring, you had to speak about the elephant in the room. But if you had to talk in a more positive way, what are the take-home points you want about the national?
Yeah, see, conceptually, there is no doubt that this has to be done. And as Dr. Amit said, I think it's long overdue. A country like India could have done this, could have started on this process at least 10 years ago. And by now, we could have at least reached somewhere. Unfortunately, there has been lack of political will, irrespective of governments and so on, political parties and so on, to bite the bullet. You have to take that big decision that, look, if we want to improve the quality of care that we give our citizens, and which we claim every day that we actually want to do this, then we will have to make certain difficult decisions. So I think that the first decision that they need to make is to bring this law in Parliament. And in parallel, there is going to be a data protection law anyway. I mean, it's been in the works for a long time. There is already a data protection bill which has gone through multiple iterations, but it has not become a law. So that will happen. I mean, irrespective of the health record or otherwise, there will be a data protection law which probably in the next couple of years will be a reality. What we need now is the law that mandates electronic medical records. Once that happens, then it will have a domino effect, because once every physician in this country needs to enter data into a system, then the resistance part actually goes down. You don't get your insurance payments if you don't use electronic medical records. That's the first disincentive. Say that, and you see the number of people who will come into the system from the private sector side. State governments make it mandatory. So it will have a domino effect on creating this entire, digital sort of platform that we actually look at. But without these two things happening, you can throw more and more money at it. The problem is not money. Money is not the issue of this particular thing. You can throw resources, you can throw money, but if you don't have the enabling legal framework, look, I've studied Australia, I've studied Singapore, I've studied UK, I've studied US. I don't think any country managed something like this without having laws in place, and we need those laws.
Yeah, thank you, Sumant. Your closing comments, Nalin?
I have one very interesting comment because, how do you, fortunately, this business of EMR, etc., and making guidelines started quite some time back, but now there is a serious intent. And if you look at a few other schemes that have been started, especially the Janani Suraksha Yojana and the Janani Shishu Suraksha Karyakram, wherein the government gives money, and I have seen this happen in my hospital here, it's very surprising, 3,000 rupees plus 2,000 rupees in each. When a lady delivers, especially the tribals out here, when she delivers, she's given 7,000 rupees in hand by the government. So they register, they utilize these facilities, and all this is done only if they have registered. So there are incentives, there are ways of, this thing is already implemented in a lot of ways. So the insurance or the funding by the government for these various schemes linked to the ABHM, it has become quite a popular thing here, and the National Health Mission is doing well. I see a very, very good future to provide equitable healthcare to the masses, even in difficult areas. Privacy is a concern. The Indian IT Act needs to be amended, though it is pretty decent, though enforcement has been difficult. If you read the IT Act, any leak or breach of information from your hospital, the senior most administrator is held accountable. But it becomes very difficult to identify, pinpoint, and then start enforcing these laws. So we all take that for granted. The bottom line is that the laws have to be in place. But overall, I think we are doing a good job approaching it. The direction is good. The bottom-top approach is good. Inclusivity is fantastic, and training of trainers and utilizing people at the grassroots levels, including ASHA workers, etc., I think is a very, very good strategy.
So Radhakrishna, when you suggested this, you discussed with Shariff and suggested this topic, do you think we have, kind of achieved what we set out to?
I would say yes.
Actually, I was thinking of all the digital innovations is done which are visible in the form of his laboratories and all that. But this is a very, very significant thing is talked about the governmental policy and his involvement in consultant policy. But again, I echo what Sumansi Raman says, because I work in a corporate sector, and corporate sector, some of the corporate sectors are very reluctant to buy good software. And most of what it's used is like in a word format, which can't be analyzed, it's not data. And that's what is happening. And doctors are not at all keen on entering any data anywhere. Nurses are not keen on entering data in the operating rooms. This hasn't changed one bit, I should tell you that. In spite of the fact that Shariff has got great hopes that all the data is integrated. Where is the data coming from the private sector? And there's no law to make or take a stick and make these people, the private sector people, to put in data, real data, and connect it to a central network. I don't know, actually, and Nalin is so hopeful. But maybe in your institutions, which are very well managed and controlled, it's possible. But in a lot of private sectors,
where there is money, that is, the insurance and the billing part of the hospital information systems are very well implemented in corporate hospitals.
It's very, very true. Billing is there.
Billing and insurance. Yeah. Whatever deals with money. Yes.
Somebody said that if you find out how many fever cases are there in the hospital, you go to the pharmacy and from there you can make out the data. I mean, that's the way it is. It's not the real way. Sadly, that is true. The COVID scene that happened, there's no data anywhere keyed into any computer. People just came, they went, what people got, God only knows. I mean, how can we ever comment on COVID data in India? That's the way it was. But I hope, this sort of talks will push us towards thinking scientifically and do something more in that direction. It's a wonderful lecture.
Your closing comment, Shariff. I mean, there are pluses and there are minuses, but your closing comments.
No, I really appreciate the blueprint. I think everybody, we don't have any second opinion about the, the thoroughness with which that blueprint has been created. I think this is what we should appreciate, and we are quite ahead compared to the rest of the world in at least having a blueprint. And how well are we going to realize that and implement the system depends on so many other things. And one important thing is whether it should be made mandatory or not. The other thing is the legal and regulatory framework. And even if we have the framework, how well are we going to implement those? There are laws, but who is going to enforce them? And it is very difficult to enforce any law in our country. So I think the system which we are thinking of, which is very good, but then how well are we going to get it implemented is a question. So yeah, I thank all of you for patiently listening to me. So
thank you, Shariff. Like somebody else commented before, thank you for really making it easy for dummies to understand. Like you brought it down to the level where, and believe me, you never used any technical jargon which was possible to avoid. So thank you so much. And I think as doctors, we have also failed in the sense that I don't think any doctor's body has ever pushed for electronic health records or any sharing of data or data privacy or anything. So at least your talk and interaction with Nalin and Sumant has at least made a few of us today more aware of what is possible and what needs to be done. So thank you so much, everyone. And for want of a better word, for such a dry topic, we had so many people who stayed right up to the end and so many questions. So thank you, Nalin and Sumant, for making it so interactive. And thank you, everyone else.
I also want to thank Nalin and Dr. Sumant very much, actually, for making it so lively. Actually, I was missing out on so many things.
Thank you, Dr. Shariff and Dr. Nalin.
Thank you
so
much.
Interactive.
Pleasure being with you, Sumant and Shariff and the rest of us.
We'll be meeting out again some time for some other aspect of digital healthcare. So we'll meet again in the coming weeks. Till then, next week we'll have another episode of Marvelous Medicine. Till then, take care and stay safe. Good night.
Thank you. Thank you.
Thank you, everybody.